Good afternoon, dear colleagues. It is a pleasure and a privilege to welcome you to the Sanofi Genzyme Symposium at the European Charcot Foundation Virtual Meeting 2020. In the following 45 minutes, we will try to provide an answer to the question elected to be the title of the symposium: what lies ahead in multiple sclerosis disease management? Next. The faculty of the symposium includes myself, Dr. Diego Centonce of the Department of System Medicine at the University of Rome Tor Vergata, Dr. Antonio Scalfari at the Imperial College in London, and Professor Patrick Vermersch, the University of Lille. Next. The agenda. The first presentation will set the scene, highlighting new challenges in MS disease management. The presentation of Dr. Scalfari, entitled Roadblocks Ahead, Relapse and Progression, will discuss how strong or weak is the link between the acute episodes of inflammation and long-term disability. The talk of Professor Vermersch is entitled The Road Ahead, Targeting New Pathways, and will give us an update on the new perspective of MS treatment as provided by the pharmacological modulation of new cellular pathways in the immune and central nervous systems. Let's get started with the first presentation.
Good afternoon. In the next few minutes, I will briefly discuss current challenges in multiple sclerosis management, as they have been emerged based on recent progresses in the understanding of the disease. This is my disclosure. A first concept is that damage begins early in the disease course, far before clinical symptoms appear. This representation of the MS disease evolution shows that all mechanisms of damage, acute inflammation, axonal loss, and chronic inflammation, but also synaptic damage in the gray matter and brain atrophy, are already ongoing when the clinical threshold of the disease is reached due to the temporary loss of compensatory mechanisms in relapse-remitting multiple sclerosis or to their permanent disruption in the progressive phases of the disease. A rather surprising discovery in the last decade is that brain atrophy is accelerated in MS patients across all stages of the disease, implying that even when MS is clinically silent or is at its onset, processes of tissue damage are taking place at indistinguishable rate compared to the more severe progressive forms. Based on the above considerations, it can be predicted that also the RIS stage of MS is characterized by similar rate of atrophy, in line with the idea that the pathological processes of tissue damage and the clinical manifestations of MS are disjointed. Acute inflammation-independent tissue loss abolishes the compensatory mechanisms that are crucial to minimize the clinical manifestation of the disease, and both physical and cognitive disability accumulates over time, even when no further episodes of acute disease are seen. Despite the fact that physical and cognitive disability follows both acute inflammation-dependent and independent tissue damage accumulation, the current MS armamentarium is essentially aimed at reducing the risk of relapse and disability worsening by targeting acute focal inflammatory damage only. Clinical and conventional MRI parameters only explain part of the deteriorated quality of life of MS patients and do not properly capture, for example, other manifestations of the disease that also contribute to affect patients' quality of life, such as fatigue, cognitive dysfunction, mood disorders, bowel and bladder dysfunction, sexual disturbances. No surprise, therefore, that a further advancement in MS treatment goals is desirable. The introduction of the concept of NIDA made more ambitious than in the past the goal of MS treatment, but other imaging and laboratory parameters are ready to be introduced in clinical practice to better inform clinicians on the ongoing process of smoldering, inflammation, and subtle neurodegeneration that accompany focal inflammatory damage and the resulting clinical worsening. Despite the fact that treatment of MS with the currently approved DMTs can virtually abolish the occurrence of new relapses, disability accumulation is only reduced compared to untreated patients, and transition to the secondary progressive form of the disease is not prevented. In order to address this ongoing disease progression, it is therefore necessary to look beyond relapses in focal MRI activity. Beyond the focal white matter inflammation and the resulting axonal transection, MS is more complex than previously believed, causing, for example, gray matter dysfunction and damage since the early stages of the disease. It follows that new therapeutic targets are needed to combat neuroinflammation and neurodegeneration. To sum up, current MS treatment focuses on reducing relapses and disability through action on the adaptive immune system. Despite controlling acute focal inflammation, patients continue to worsen, which may be attributed to chronic smoldering inflammation inside the CNS. Quantification of smoldering MS requires measurements beyond conventional imaging. Addressing newly identified disease mechanisms within the brain is the next step towards the future of MS therapy. Thank you.
Thank you for inviting me to be part of this interesting symposium. I'm going to discuss how our understanding of mechanism driving disease progression is actually changing and its implication for disease management in the future. These are my disclosures. It is widely accepted that in MS, ongoing focal inflammatory activity is the dominant features during the early stage, causing axonal loss, which then becomes prominent during the progressive phase of the disease. However, it is also known that a neurodegenerative process is present since the start. It continues throughout the entire course of the disease, underlying the progressive phase, and to a large extent probably be independent of the focal inflammatory activity. And the role of relapses in determining late outcomes in MS remains quite controversial. Compelling evidence from natural history study demonstrate a strong association between early relapses and long-term disease progression. Patients with a higher number of relapses during the first 2 years experience faster disease progression, especially during the secondary progressive phase when they accumulate disability much more rapidly in comparison to patients with a lower number of early relapses. But the predictive effect of relapses diminishes with time, and late relapses have much weaker correlation with disability accumulation, as you can see in this Kaplan-Meier analysis. In addition, in clinical practice, we know that the lack of ongoing clinical and radiological focal inflammation, which is the so-called NIDA2, might give us a sense of false security. It is not uncommon that not active relapse-remitting patient keeps reporting this deterioration with subtle physical and cognitive worsening. Therefore, our ability of efficiently suppressing the acute focal inflammatory activity with currently available disease-modifying treatment does not necessarily translate into halting the disease progression. The mechanism underlying the progressive disease needs still to be fully addressed, and ultimately preventing the end-of-organ damage remains an unmet therapeutic need. And over the past few years, we have learned that progressive MS is preceded by a prodromal phase. Evidence indicates pathological mechanism underlying progression start much earlier than its clinical onset, and gradually become evident similar to other neurodegenerative conditions such as Parkinson or Alzheimer's disease. We learned that a subject with radiologically isolated syndrome can not only develop a classic relapse-remitting form of MS, but also can develop a primary progressive course, in some cases even after 10 years from the detection of risk. And the cortical pathology is known to play a key role in determining progressive MS, and both cortical lesions and brain atrophy are known to be detected among subjects with risk and to occur during the early stage of relapse-remitting MS when the clinical progression is not evident yet. In addition, axonal loss and degeneration can occur in the context of active demyelination and is known therefore to be an early pathological features of MS. Therefore, overall, taken together, these evidence indicate that biologically, progressive MS is active since the onset, probably since the onset of relapsing remitting MS, but it remains to be difficult to detect it clinically. And because of biomarkers, it is challenging to distinguish disability accumulation related to poor progression or related to incomplete recovery from relapses, especially when relapsing and progressive phases overlap. And this was addressed a few years back by George Eber's group, which addressed the problem of pinpointing the clinical onset of secondary progressive MS, which is often clouded by ongoing relapses. And to overcome this problem, they decided to focus on a quite rare clinical phenotype, the so-called single attack progressive MS. These are patients who are distinguished by a single demyelinating attack at onset, which is then followed by a period of stability, after which the secondary progressive course would occur. And among single attack progressive MS patients, because of the lack of ongoing relapses, the clinical onset of secondary progressive MS was much more easily pinpointed, much earlier than the average SP patient. Indeed, the time to onset of progression was shorter than average, 8 years, and the EDSS score at onset of secondary progression was much lower than the average EDSS score for SP patients. Ebers reported that among single attack progressive patients, progression could even occur at EDSS1 because of the occurrence of exercise-induced ambulation impairment or because of the emergence of pyramidal synod examination. And overall, therefore, this clinical observation indicates that there is an element of progressive disease since the early stage of the relapsing remitting phase. And this was nicely confirmed in recent study from the pool analysis of the ocrelizumab trials, where it was used a composite outcome to detect disability accumulation. A composite outcome would more easily detect disability accumulation compared to the EDSS scores alone. And quite interestingly, the analysis demonstrated that in both groups treated with interferon or ocrelizumab, most of the disability accumulation was unrelated to relapses. These are patients early in the disease course with an average or a mean disease duration of 6 years. It is impressive that such a large proportion of patients in both treatment groups experience clinical worsening despite the lack of ongoing relapses, thanks to the therapeutic relapse suppression. So this further confirmed that there is an element of progressive disease since the early stage of the relapse remitting phase. And in line with Eber's observation, most of peer events were actually driven by ambulation worsening as detected on the T25 foot to walking test. Therefore, in addition to the acute focal damage lesions, the disease progression appears to be driven by a chronic diffuse pathological process, which some people like to call a smoldering process since the early stage, which ultimately will lead to a loss of global cognitive and physical functions. An exact mechanism behind this smoldering process remains to be fully elucidated. This can be driven by both innate and adaptive immunity, in combination with oxidative injury as well as mitochondrial damage, and of course also age-related exhaustion or reserve capacity. And interestingly, in the pool analysis of the ocrelizumab trials, it was assessed which factor predict the occurrence of progression independent of relapsing activity, and the changes in the whole brain as well as in the gray matter volume stand out as the two main drivers of peer events. In contrast, as we might expect, raw events, so relapsing associated worsening events, were actually influenced only by the occurrence of gadolinium-enhancing agents, suggesting that there are certainly distinct pathological mechanisms which drive PIRA and raw events. And analysis of the real-world cohort from San Francisco confirmed that a large proportion of relapsing remitting MS patients experience disability accumulation unrelated to relapses. They like to call it the so-called silent progression. And the analysis further highlights the key role played by the whole brain atrophy. Here I highlighted only patients without any relapsing activity, and those who experience EDSS worsening are certainly distinguished by a much faster rate of all brain atrophy, which is one of the key probably key pathological drivers of silent progression. But it's not only the brain atrophy, but also the focal cortical pathology, which plays an important role since the early stage of relapsing-remitting MS in determining progressive MS. And this probably explained the accumulation of disability much better than the white matter damage. The extent of the focal cortical pathology at disease onset influence the risk of becoming progressive, and those patients with a larger number of cortical lesions at onset were a higher risk of entering the secondary progressive phase and had a significantly shorter latency to progression. And overall, the accumulation of cortical lesions over time drives the gradual transition to secondary progressive MS. A recent study demonstrated the prognostic relevance and importance of the so-called smoldering enlarging lesions, which are distinguished by a rim of microglia inflammation, which feeds the inflammatory environment inside the lesion itself, leading to remyelination failure and axonal damage. And the presence of smoldering lesions has been shown to be correlated with more severe clinical and radiological outcomes. And other studies also demonstrated the importance of innate immune cell activation, which is known to occur early in the disease course, be present in the CIS patient. In a recent study, it was shown that higher microglia activation distinguished patients experiencing disease progression despite the lack of any ongoing relapsing activity. And finally, also, the meningeal inflammation, which is thought to be linked to the extent of the cortical pathology, is also known to be an important driver of the disease progression. But overwhelming evidence indicates that age is probably one of the key drivers of MS progression. The probability of becoming progressive increases with age. And most clinicians would agree that progressive MS is very rarely observed at young age. Older age and onset of the relapse-remitting phase strongly increase the probability of entering the secondary progressive phase, associated with a shorter latency to progression. In addition, the probability of experiencing a primary progressive onset and primary progressive cases are very rarely observed among pediatric patients. And pediatric patients, when they develop a secondary progressive course, always in adult life. Therefore, with the exception of few cases, progressive MS is not a disease observed at young age. If we take together all this evidence, we can outline a unified age-related disease model where the silent progression starts much before the clinical occurrence of progressive MS. It's already active in early stage of relapse-remitting MS or among patients with radiological isolated syndrome. This process remains subclinical for a while and then gradually emerges clinically once an age-related threshold is overcome. And this is likely to be driven by exhaustion of brain reserve capacity secondary to remyelination failure, iron accumulation, or increases of vascular comorbidity. And interestingly, in line with this model, a recent study from Basilea presented at the ECTRIMS showed that serum level of neurofilament are actually higher among patients more likely to experience peer event, and the level tend to increase by growing old. Therefore, to conclude, peer events accounts for a large proportion of early disability accumulation, are certainly driven by pathological mechanisms which are probably unrelated to focal inflammatory activity. Therefore, we can certainly modify the disease course with currently available disease-modifying treatment, but addressing smoldering mechanisms behind the peer events remains an unmet need, and I think it represents the therapeutic challenge for the future. And I thank you for your attention.
Hello, everybody. My name is Patrick Vermersch from the University City of Lille in the north of France. I would like first to thank Sanofi for inviting me to speak in this symposium during the European Charcot Foundation. Probably much better in person, but we need to do as we can, so it's a virtual meeting. So first are my disclosures. So as you know, treatment goals in MS is really a moving target treatment goals need now to incorporate new data concerning inflammatory, but also neurodegenerative outcomes. During the older days, we consider only some clinical aspects, relapses or disability progression. But now a realistic target is really what we call NIDA 3, no relapse, no disability worsening, and no MRI activity. But already today, and not only in clinical trials, of course, not in routine practice, but now we consider also other aspects of the disease related more to the neurodegenerative part of the disease, I mean brain volume. And now we can consider NIDA 4, incorporating no loss of brain volume into the NIDA 3. And in the future, because we have new biomarkers, not only imaging, but also based on some biological aspects, for example, neurofilaments, for example, in the CSF, but also in the serum, because of new technologies like CMOA technology, for example, and also neurofilaments are related to both inflammatory and neurodegenerative components of the disease. And so we can implement, for example, neurofilament in the targets. Which mechanisms should we target? I will say definitely that MS is a unique disease. However, we have different forms of the disease, different phenotypes of the disease. Even I think there is a large continuum between these phenotypes. The relapsing-remitting MS with new waves of inflammation, probably the responsibility for relapses, and also GAD-positive lesions, new T2 related to maybe the entry of hyperactive lymphocytes into the CNF through disruption of the blood-brain barrier. Probably more lesions in the white matter than the gray matter. And progressively, secondary progressive MS or maybe primary progressive MS a little bit later in the disease process, or the lesions are more diffuse, both white matter and gray matter. Even we know that we have also in the relapsing-remitting MS, of course, we have many lesions in the gray matter, deep gray matter, but also in the cortex, cortical demyelination, and also a new area of research concerning the slow expansion of pre-existing lesions, so the chronic but active lesions. And we know that this slow expanding of pre-existing lesions, so related probably to the smoldering inflammations, are maybe a lot of responsibility in the slowly progressing MS, and probably responsible of what we call the PIRA, progression independent of relapse activity. I will come back later. And in progressive MS, but also in relapsing-remitting MS, but probably more in progressive MS, we have the so-called compartmentalized inflammation in the meninges, but also the diffuse inflammations in both white and gray matter. Of course, in addition, in the late stage, late progressive MS, we have some accumulation also of neurodegeneration related to age, or comorbidities, vascular comorbidities, or diabetes, for example. And we know we have also some lesions related to the accumulation of iron in many cells into the CNS. So considering together, we have a mix of many types of lesions, but I would like to say that maybe at all stages of the lesion, in all phenotypes of MS, we have some degree of inflammation, but the inflammation probably not the same during all the phase of the disease. So to target the disease mechanism into the CNS, I will not go into the details of all the aspects of the pathophysiology of MS, but you know, we maybe a common thinking with activity of B and T cells at the periphery. This activity So the cells are able to go through the blood-brain barrier and into the CNS. They are again activated by antigen-presenting cells, activated by some cytokines, and also related to the activity and the link between many types of immune cells into the CNS, and probably major role of some cells into the CNS may play a major role, reactivate beyond T cells, for example. I will say microglia, macrophages, but also reactive astrocytes. Reactive astrocytes are also part of the innate immunity, like microglia, like, for example, neutrophils in the periphery. And we know that into the CNS, both adaptive immunity and the innate immunity may play a major role to axon degeneration, neuron damage, and finally, cell death, which also exacerbate inflammation into the NES. So a vicious circle into the CNS. And of course, this lesion contribute to progression and exacerbate disability. So maybe let me come back to microglial activations associated with neuronal damage and disease progression. We know that into the CNS and into the lesions, probably more at the periphery, we have activations of microglial cells and macrophages. And we know they are the dominant immune cells found in MS lesions. And probably more, at the periphery of the chronic active lesions, we have a lot of myeloid cells with specific markers, as you can see, with a lot of all-red staining, meaning that we have myelin damage at this stage in neutral lipids. You see here in this cartoon, early active lesion zone, so very close at the border of the chronic active lesions. And if you look now, some correlation between this activation of the innate immunity, definitely we have some correlation with brain atrophy of some change in the distribution of the volume ratio in MS patients. If you consider only patients with no relapse, so no focal activity, probably, but if you consider the normal appearing white matter volume ratio on the left, and also normal appearing white matter volume ratio, but only at the periphery of lesions, the perilesional normal appearing white matter distribution volume ratio. You see there is a difference between patients with disability progression versus patients with no disability progression. And it's highly significant for both the normal appearing white matter, but probably, as you can see, the differences are more important at the periphery of the chronic active lesions, perilesional normal appearing white matter. And again, concerning microglia is not involved only in MS, but finally we know that in other neurodegenerative diseases, microglia may also play a major role. For example, in ALS, on the left, using an animal model, a mice with increased expression of the superoxide dismutase 1. If, for example, if we lowering the superoxide dismutase expression, we have an increase of the percentage of survival. So decreasing this expression of this enzyme in microglia, we improve the survival of the mice. You see also the duration late disease is increased in mice with a lowering of SOD expression. So decreasing the activity of microglia, we increase the survival of these mice. And on the right, in Parkinson's disease also, if we inject LPS, which is a strong activator of the immune system, they inject LPS into the substantia nigra, we know we have a strong activations of microglia in these animal models. And as a consequence of this overactivity of the microglia in animal models, we have some functional changes such as dopaminergic neuron attenuation, in one interleukin-1 dependent manner. So interleukin-1 is a strong pro-inflammatory cytokine. We increase the aggregation of alpha-synuclein, and we increase the dysfunction of motor function. So microglia is also involved in other neurodegenerative diseases. So we know now with strong, maybe some overlaps of some common pathways for many of these neurodegenerative disorders, including MS. So to combat neuroinflammation and neurodegeneration, interestingly, we have no new therapeutic targets, and we have, of course, needed, and we have some very promising targets. For example, BTK as Bruton's tyrosine kinase, also a new receptor interacting serine threonine protein kinase, RIPK1, also the receptor for CSF1 and the NLR family. I will not go into the details of all these targets, but definitely you see the very increased number of new targets for our patients. So first of all, the Bruton tyrosine kinase, and as you know, we have already almost in the phase 3 trials for BTK inhibition in MS. Interestingly, BTK are involved in both adaptive and innate immune signaling. BTK is a member of the TEC family that regulates signaling and downstream on the for B cells, but also on myeloid cells. I will not go into the details. You see on the cartoon on the left, you see the modulation of B cell functions are dependent of some stimuli, and one of the stimuli is BTK signaling with sync, and we have, if we inhibit the BTK, we have a decrease in B cell maturation, decrease in B cell proliferation, decrease of the antibody production, and a decrease of the pro-inflammatory cytokine. So interesting way to not to deplete B cells, but decreasing the activity of B cells and the maturation of B cells. On the right, also the BTK inhibition could target the innate immunity with some common pathways expressing this receptor. We decrease the microglial activations, also decrease the pro-inflammatory cytokine secretion by myeloid cells, so mainly microglia and macrophages. There is no impact on T cells, which is very interesting. However, we have some impact also. Natural killer cells and plasma cells could be also of importance for MS. So this dual activity is really interesting to tackle this neurodegenerative disease, including MS. So because we know that BTK expression is increased in lesion tissue more from progressive MS than for relapsing remitting MS. But it's not really specific, but that's true that it's quite more impressive in progressive MS patients. So you see on this slide, if you are at the lesion rim of the chronic active lesions, we have maybe a number of microglial cells which are expressed, and you see some correlation with demyelination by the Luxol fast blue. And also if you have some correlation with Bielchowski for neurons, for axons, we have also some strong correlation between this activity and also some neuronal damage. So clear correlation between microglial activations with iron, for example, demyelination and neuronal damage. And if you look at the expression of BTK, which is increased in progressive MS, as you can see, as a lesion rim again, you see here a myelinated region, demyelinated region. The expression of BTK is much more expressed at this level, at the lesion rim of a chronic active lesions. And if you compare the BTK positive cells, for example, comparing normal appearing white matter with lesions, you see a significant increase of the number of BTK positive cells. And BTK was upregulated, as you can see here, in lesion protein. You see, if we compare healthy controls, relapsing MS, SPMS, PPMS, you see the fold change you see LC controls, maybe not so different between LC and relapsing remitting MS, but definitely you see maybe a twofold change secondary progressive and something like fivefold change in PPMS. If you look at the expression of the RNA, you see here also comparing LC, relapsing MS, SP, PPMS, and MS, you see significant change, significant increase of the expression of the mRNA or BTK, of course, in MS patients, MS tissue. And also another target we can discuss, I will not go into the details, but targeting the CSF1 receptor, because this receptor is expressed on many mononuclear phagocytes, including microglia and again macrophages, and also dendritic cells. Dendritic cells may also play a major role to present antigen, for example, to immune cells. So maybe targeting and decrease the signaling of CSF1R could be interesting also and already under investigation in the treatment of some autoimmune disease like MS, arthritis, or in lupus. Maybe CSF receptor expressed here, as you can see, to modify the expression and the activation of some immune cells. And other target, RIPK1 kinase, also as a crossroads of inflammation and cell death. We know that the RIPK1 is key upstream regulators and control also inflammatory signaling, as well as the activation of multiple cell death pathways, including apoptosis or necroptosis, which is necroptosis related to iron or not, but also may play a major role in this long list of neurodegenerative disease and could be also interesting. A target you see here, for example, targeting the toll-like receptor on the trail, and we know there are main drivers for cell death receptor. Another possibility is to have a look on the signaling of the NLRP3 inflammasome in multiple neurodegenerative disease, because we know NLRP is overexpressed in many neurodegenerative disease. It targets also the innate immune system. So definitely also we can modulate or decrease this inflammasome related to NLRP3. No time to go to the details. Of course, we need new tools to evaluate this activity and to have a better look of the smoldering inflammation, what is related to microglia, what is related to deposits of iron at the periphery. We have some interesting new sequences for MRI, you know, the phase rim, slowly expanding lesion. You see here this activity at the border, at the periphery of the chronic lesions. You see here we are able to have a follow-up of these lesions and the new sequence, MRI sequencers for that. The PET, also PET scanning, PET imaging is very interesting because you are able to have a follow-up of what happened into the brain of patients concerning demyelination and remyelination, but also microglia. We have new biomarkers, new ligands we can use with PET. Of course, you know, probably the neurofilament is now important and probably that one of the best biomarker we have, and to try to validate in large cohorts of patients, because it's very easy to measure soluble neurofilament into the cell. Important because we need to assess. So finally, you know, targeting PIRA, progression independent of relapse activity, probably the main driver of the progression of the disease for both relapsing remitting MS and probably more for the progressive MS patient, both SPMS and PPMS. You know this cartoon, patients continue to accumulate disability despite some treatments. However, you know, the curve is better. And also the key point was to decrease the risk of a patient switching from relapsing remitting MS to SPMS, and in the near future with these new drugs, new targets, probably, you know, the unmet need in here, the EDSS score probably to decrease this rate of progression based on EDSS or other markers of disability progression, and again, to delay the time of switching from relapsing remitting MS to SPMS, I hope in a near future. I would like to thank you for your attention and ready after for questions. Thank you.
Thank you very much, our speakers, for brilliant presentations. I can't see any question actually, so I think we can move to the concluding remarks. Next. So current MS treatment focuses on reducing relapses and disability through action on the adaptive immune system. Despite controlling acute focal inflammation, patients continue to worsen, which may be attributed to chronic smoldering inflammation inside the central nervous system. Quantification of smoldering MS requires measurements beyond conventional imaging. For this reason, addressing disease mechanisms within the brain is the next step towards the future of MS therapy. I wish to thank you all for your presence in this meeting, and of course Sanofi Genzyme for organizing, and my co-speakers, Professor Dr. Scalfari, for taking part in this interesting symposium. Thank you very much. Okay, I see one question, which is, I think we can take it. Do you switch progressive non-active patient on interferon beta cell therapy for progressive course? I think this is to Professor Vermes. A question on the switch.
Maybe if I can answer and try to answer this key question. So it's a case of a patient treated with interferon beta to switch to another drug. Of course, if the patient is non-active, it's very difficult. I think we need to try new drugs to include this patient into clinical trials, because to the best of my knowledge, we have not real drug showing an efficacy on non-active progressive MS. However, we have an approval, of course, in some countries for anti-CD20. But in fact, if you look at the stratification of the population and the results in the oratorio trial, for example, the efficacy seems to be much better in the progressive active group compared to the non-active group. So, of course, we have so many unmet needs for progressive and non-active patients, unfortunately.
Yeah. Another question, I think, again for Professor Vermeersch. How do you explain the BTK inhibitor impact on relapsing multiple sclerosis, given what you have reported today?
Of course, MS is a unique disease. There is an overlap, of course, between all the phenotypes of MS. And we know that early we have a degenerative process, and very early also we have the involvement of both adaptive immunity but also innate immunity. We have in normal appearing white matter at the border of focal lesions in the white matter, but also into the cortex and in the thalami. We have involvement also of the innate immunity. We have microglial activation in many parts of the CNS, and maybe targeting both adaptive immunity, decrease the proliferation of B cells, but also acting into the CNS, because the drug really, BTK inhibitors, penetrates quite well into the CNS. We also decrease this innate immunity related to microglial activation. It's true. We will see in the future maybe the best targeted patients relapsing remitting MS or relapsing MS in general, or purely progressive MS, maybe if it is good or not to treat these patients with BTK inhibitors. But we have in the near future, we have ongoing trials with many companies evaluating BTK inhibitors in both relapsing MS, but also in progressive MS. But we need to wait to have the results.
Is there any other question? If not, I think our time is over, and I wish to thank you again, all participants to this symposium and Sanofi Genzyme for organizing this interesting discussion around a very, very important topic. Thank you very much again.